Okay, I'm Sarah Gordon. I'm going to be closing our program. I am a health policy researcher at the School of Public Health, and I'm going to be talking about my research comparing postpartum healthcare utilization and spending in Medicaid versus commercial insurance after birth. So the Medicaid program is a huge payer for pregnancies in the US, pays for almost half of all US births. And historically, at least under federal law, states actually provide only a limited amount of coverage for pregnancy from when someone gets pregnant through about 60 days postpartum, after which someone needs to qualify for Medicaid under a different basis of eligibility in order to stay enrolled. This is basically a hole in our already very fragmented health insurance system, which the Biden administration has worked very hard to try and incentivize states to fix. Full disclosure, I've worked a lot on this policy as a senior advisor at HHS, but this is not HHS work, doesn't represent HHS. So they gave states an option to extend coverage for anyone who's pregnant in Medicaid from 60 days to a year postpartum. So you can see in these maps, the gray states are states that have not adopted this extension. The blue, green states have. So you can see even in just the last 2 years, there's been very strong interest in this, uptake of this policy, except for Arkansas. Don't know what's going on with Arkansas, still hold out. So I was really interested in what would happen when you give a bunch of people the option to basically shift from transitioning to commercial insurance after birth to being able to stay in Medicaid, right? So we're basically moving a bunch of people from one type of insurance to another. And so there's a lot of interest in sort of understanding what the utilization and costs and spending implications of this might be. So I used data from the state of Colorado. They're all payer claims database linked with income and birth record data. I've also used this data for several other projects because I have continuous income data, which is great for regressionist continuity. So if anyone's interested in this type of data, please reach out. We basically just looked at a cohort of people who had Medicaid paid births, and basically found that those in commercial insurance had higher use of outpatient and primary care and lower ED use compared to those in Medicaid. Total healthcare spending was a lot higher in commercial, not surprising at all to a room of economists, I know. And enrollees in commercial insurance had much, much higher out-of-pocket spending. So you can see that here plotted in this figure over the 12 months postpartum. You see basically very close to zero out-of-pocket spending for Medicaid enrollees, much higher in all months postpartum for commercial enrollees. So what is the implication of this? The shift from subsidized private insurance to Medicaid in states that have adopted extensions may mean that the federal government pays less because they're not subsidizing people who are going to marketplace plans on the individual and health insurance marketplaces. And the states will pay more, but this is a relatively low cost population. We found that basically the per capita spending for postpartum individuals in Medicaid is about $4,200 for that time period, 3 to 12 months postpartum, which is less than per capita spending for the Medicaid expansion population. So overall, this is a fairly low cost population to cover. And that's really key to state Medicaid policymakers who are very concerned about the budgetary impacts of this extension. And I think really the big finding here is that you are shifting a fairly low-income population from coverage, as we've talked about a lot, high deductible health plans, high exposure to out-of-pocket costs, into a option with very, very low exposure to out-of-pocket costs. And so people will probably pay much less for care that they seek after birth. That's it. So thank you all for coming. I'm also the host of this event. So I'm just so honored to convene everyone. I think it's very clear that there's so many cross-cutting themes. There's a big focus on insurance, a big focus on how policies and programs specifically impact low-income populations. So I think it's still so valuable to be able to do in-person convenings like this. I will just do a brief plug since I am the organizer of this event. I was asked to come up with a theme, and I focus on health equity in part because that's really critical to the way that me and a lot of my colleagues approach Medicaid research, in particular as Medicaid policy researchers. And we do have a group over at the School of Public Health, the Medicaid Policy Lab. We are always looking to grow, and specifically to grow across the river. We are honored to have Randy, at least this semester, but we encourage others who are interested in policies or programs that affect low-income Americans, Medicaid data, to reach out. And so with that, I just want to thank all of our speakers for agreeing to participate. I want to thank everyone for coming, and there will be refreshments out in the lobby so we can continue the conversation. Thank you.